Today on Cityline, an urgent call to women. We're talking about your health and how acting now could save your life.
He told me my wife had this, it's hormones.
Oh,
and he was basically just very dismissive.
How to be heard when medical gaslighting happens to you. Then we shine a light on the #1 killer of women in Canada, and it's not what you think.
Everything to do with heart disease was all focused on men.
What you need to know to keep your heart healthy.
At least 80% of your risk can be reduced or wiped out.
And later, Dr. Tony on the resurgence of hormone therapy.
I find a lot of women, they don't talk about menopause, even amongst themselves, and so they're often struggling alone.
It's Cityline with Tracy Moore.
Welcome to Cityline. We have a very special and important Wellness Wednesday planned for you. Today we're taking a deep dive into the world of women's health and the pressing issues women need to know now, like right this very second. And when we say women, we're including transgender and non-binary people as well. The goal is to expose the patriarchal systems that put women's health at risk and to empower all of us. We need to take our health seriously, right? Yeah. So we've got a great team of doctors to help us through this journey. Here to chat about an experience that is unfortunately all too common for women, our family physician, Dr. Tony Sappong, and Cityline makeup artist, Grace Lee, in the house. Thank you, both of you for coming. So I said that this is an issue that is actually common. We actually have people in the audience that have been through this. We're going to talk about gaslighting. Okay, so gaslighting, have you heard the term before, gaslighting? Yes. If you're experiencing gaslighting at work or in your relationships, it may look like having your concerns be dismissed or discredited. But what happens when gaslighting takes place in the doctor's office? Grace, this happened to you, but first I'm going to go to Dr. Tony. How would you describe gaslighting as it relates to women's health?
Yeah, I think it's the experience of having your symptoms dismissed by your healthcare provider. Or I think what's actually more common is having them attributed to other factors. So things like stress or anxiety or hormones or it's natural part of being a woman, those sorts of things, without any real history or physical or investigations to fully investigate what the actual concerns are. And it, of course, can lead to problems where things are missed, important things, and they can have health consequences.
Well, speaking of important things, Grace, you have been through this. You experienced this when you had complications during perimenopause. Can you tell us your story?
So last year, let's just start with, I had my period for 6 weeks. So it was straight. It was, and it wasn't just like a light spotting kind of period. It was 6 weeks of torture.
Heavy flow.
Yes.
Yeah.
And so rewind, I think at week 2, I did realize that this is not normal, and I went to see my family doctor. My family doctor then ordered an ultrasound, which again was going to take about another 2 weeks. There was COVID restrictions. You know, even seeing a family doctor was hard. And then then I think at like week 4.5, I called my doctor and I said, it's still going. And she said, go to Emerge right now. So I waited for 13 hours to see an emergency doctor, and he did 1 blood test. He didn't even test my hormones, but what he told me when the blood test came back was that it was due to my hormones. And he was very dismissive, and it was, I just was stunned. I could not believe that I did not get an ultrasound. I did not even get an internal exam. It was just very, very frustrating.
How did this whole story end then? So you're bleeding. Like, what do you do about this situation? How did it end?
Well, so how it ended was he gave me a prescription for charismatic acid, which is supposed to stop bleeding for 50% of patients. And I was not in the 50% that it worked. And then days later, I was feeling very, very ill. And luckily, I had a friend whose husband is also a doctor and told me to go to another hospital that had an emergency OB on site.
Yeah.
So when I went there, my hemoglobin was at 72. You get a blood transfusion at 70. I was literally gray. I couldn't even drive. My husband had to drive me.
Wow.
And I had an internal exam. I had 2 ultrasounds done. I had an iron infusion that took 3 hours because my iron was super low. And I just could not believe that the care and the assessment was so vastly different from a hospital that was like 12 kilometers away.
Yeah.
It just seemed so unreal to me.
It seems unreal, and it's so much more often than we actually discuss. This happens a lot to women, Dr. Tony. What are your thoughts on this whole situation?
Yeah, medical gaslighting is a huge problem. I think this story in particular points to a few different issues. One of which is if you think about society and the fact that medicine is part of society, we have a tendency to discredit or to deem less credible women, particularly women of color, poor women, women with disabilities. And so the same biases and stereotypes and stigmas that we have in society, we find them in medicine. And they're often amplified because it's a high stakes, high stress environment. And so I think that's part of what has happened. Unfortunately, I think it also points to the fact that like our emergency departments are unfortunately under tremendous strain. They were during COVID.
Sure.
You know, the under-resourcing and lack of support, it doesn't lead us to do our best, unfortunately. And this certainly was not the best of our healthcare system, right?
Yeah.
And then I think the last thing that I really want to point out is that there's an uncertainty around women's health. And that is because of historical mistreatment of women. Essentially, up until the 80s and 90s, we were not including women systematically in our controlled trials, meaning that the research body that we have has largely excluded women for years.
So it's just
decades.
men being studied.
Men they're assumed to be the default.
Yeah.
Women often were felt to be more complicated because guess what? We have hormones.
Right.
And they
That is
fluctuate.
wild to me.
It is wild. And as it turns out, you know, we're not just men in disguise. Who knew?
We're not.
Who knew? So like it's all just very frustrating. And so there's a lack of knowledge where we do now have knowledge because more studies are being done. It's still like it's not made it into medical curriculum. It's not made it into the general body of knowledge, I wouldn't say. So there's just more uncertainty. And I think when doctors have uncertainty, they try and find that certainty. And sometimes rather than being able to say like, we've done all these investigations, we've done all these tests, we're not really sure what's causing your symptoms. Rather than saying that, they'll say something like, well, we've done all these tests, everything was normal. And I think it's actually just an insert stress or hormones or anxiety.
It's all in your head.
It's all in your, you know, just they probably won't say that, but essentially that's sort of what it feels like, and it really shuts down the conversation and it leads to things being missed, like in Grace's case.
So we're sort of discredited because I guess they think we don't really know what we know, and then they don't necessarily have the information because we haven't been studied in a lot of clinical trials. So we've got a double whammy going on.
Yeah.
And Grace, I'm just wondering, did you feel able to advocate for yourself? What happened?
No, because he told me my wife had this, it's hormones.
Oh,
and he was basically just very dismissive.
Yeah.
Also, he is in a level of authority.
Yeah.
And he then said, well, this is a life and death emergency department, so even if I ordered you an ultrasound like you're asking, if we discovered a cyst, it wouldn't be life or death. You're not dying. So that was it.
Couple of things. I see the confluence of us sort of being raised by a generation of folks that are very much about respecting the authority, and we were raised under that as Gen X kids.
Yes.
You know, my parents are like, but the doctor said this, but the teacher said this, and you believe the teacher, and you believe the doctor. And then there's generations coming up that are like, we believe nobody and we don't care. We're in between that, right? So it's difficult to find the wherewithal to stand up for yourself. But Dr. Tony, you've got some tips for us to sort of make this situation hopefully go a little bit smoother in the future. What can we do to properly advocate when we're in this situation?
I think what Grace did was actually fantastic. Like, if you have an emergent situation and it was not dealt with appropriately, going to another emergency department or going back later is important because we don't want to miss an emergency.
Right.
Out of those emergent contexts, I think what can be helpful is taking a support person with you. They're someone who's often a little bit less stressed in the moment. They can hear things a little bit better, perhaps. They can ask more questions. They can just be your advocate in that scenario.
And strengthen numbers.
Exactly.
You probably feel a little bit
Yes.
more comfortable, like you're with somebody.
Exactly. And then often if you're having symptoms over a period of time, I'd say write them down. And then also write down all of your questions so that when you go into the doctor's office, you're armed with as much information and you can have really full conversations and make sure nothing gets missed. Because often if there's, if it's a high stress situation, it can be hard to remember all of the things you wanted to discuss.
Yeah.
And then other things to know, you can always request copies of your records or your results. You can also always request a second opinion, so getting a specialist consult.
Yeah.
And then also just, knowing that you have the opportunity, like if you really feel that something was missed, you can always ask in that moment, like, hey, look, I understand that you would not like to order this test, but I'd like you to document in my chart that you are refusing this investigation and the reasons why. It may not change anything about what's done, but it causes a moment of pause that might be valuable in that moment.
I love this advice. Thank you so much, both of you, for sharing. I'm happy you're on the other side of it. Grace, oh my goodness. There's so much more coming up. Stay with us, everyone. Oh my goodness. Coming up, what you need to know about a hidden breast cancer risk.
The recommendations that were made in Canada were based on actual flawed data.
Welcome back, everyone. Okay, there are many factors that can affect your breast cancer risk. Here to discuss how age and breast density play a role is surgical oncologist Dr. Mojola Omole, always here to help us out with your info. Thank you. Now, Dr. Omole, in the U.S., the recommended breast cancer screening age is now 40. Why have you been advocating to have that change happen in Canada? Because in Canada, we're still stuck at 50?
So it really depends on what province you're in.
Okay.
BC, you can self-refer from the age of 40. Alberta is 45. And then all the rest of us in the middle and going east is 50.
Okay.
So part of it is, first of all, we know that the recommendations that were made in Canada were based on actual flawed data. And they grouped people together, and it wasn't as accurate. In the US and the UK, which is similar, especially the UK being heterogeneous the way we are in Canada, they start screening at 40. We get our bang for our buck in terms of screening and preventing people dying from breast cancer when we start screening earlier. And that's what the task force has come out with. In addition, we know that when we look at certain groups of people, so people from Chinese descent, women from Latin America, people from Latin America, and also people who we consider black, but mainly it's actually people of West African diaspora population. So anyone from West Africa or part of Charles Slavery, so African Americans in the Caribbean, we actually all present an earlier stage of breast cancer than our Caucasian counterparts, probably about 10 years sooner. So for example, this shows you that what you would feel. So the biggest one is what you actually would feel if you were feeling a lump in your breast that's cancerous.
I'm just going to pick that up for them to show them. So if you're actually doing a breast self-examination, it's got to get to that big before you feel anything. So that's a big bobble.
And the top one is what a mammogram picks up. So
this little bobble is what the mammogram would pick up, which is why you need the mammogram.
And what that translates to is a difference in your stage. And so at this stage, you might just have surgery, maybe radiation, and some medication.
Yeah.
As you get bigger, your chances of it spreading and you having to have chemotherapy goes up. So that's why it's important to screen earlier and to screen yearly.
Okay, that's a very good point. And it's interesting that it has to be that big for us to actually feel it.
Yeah, it's pretty big.
Oh my goodness. So journalist Katie Couric, a lot of people know this, has been vocal about the importance of mammograms after her own breast cancer diagnosis. She's touched on the fact that she has dense breasts. I've been told I have dense breasts as well. So can you explain what breast density is and how it affects this whole equation?
So what breast density is that you have more breast tissue. So we actually don't know the full mechanism of what it means to have more breast tissue. Does that mean that you have more estrogen that's going to be circulating in your body, which increases your risk of breast cancer? But if we look at this two props, so this is a breast that is less dense.
Okay.
As you get older, your breast gets fat replaced for some people. So think of it as, when we're doing a mammogram, we want to squish the breast between two plates. So my hands are two plates. When you have a fat replaced breast, so it's a very soft and plushy, I can squeeze that and we'll be able to see what we need to see in the mammogram. Now, if you have more dense breasts, it's harder to actually squish this. So you'll be able to see less when you take the x-ray, which is basically what a mammogram is. What it means is that things could be missed because you're not able to see things properly. And certain people do have denser breasts. So again, Asian women, people from Latin America, and black women have denser breasts. So there's less fat replacement as they're aging.
Okay. Let's actually have a look. We have a photo, right, of breast density, just so you can see the difference between these two breasts. So one breast is what and one breast is what? What is the difference between these two breasts?
So the breast that's on the left-hand side is basically this breast. So that is an older person's breast, a more fat replaced breast. So you're able to actually squish it between the two plates and see everything. What you're looking for on a mammogram is little calcium deposits, which you see when a cell is turning over fast. That's a sign of some sort of atypical cells or a sign of cancer or precancer. The other side, what you're seeing is a very dense breast. As you can see, there's a lot of white spots. So it's actually harder to see if there's a mass in there or if it's a calcium deposit in there.
Can you tell if you're doing a self-breast examination if you have dense breasts?
I would say in general, I view it this way. If your breasts still look the same as when you were like in your 20s, in your heydays, you probably have dense breasts.
Who is that? Is there someone that has breasts that look the same as in your 20s?
So a lot of Asian women do.
Really?
It still stays up there.
Oh
but if your breast is kind of like your if it's more like your grandma's breast, so it's like we're getting to like a little bit before the belly button. That's probably a more fat replaced breast with less, because the point
Maybe they're not as dense as I thought, okay? Just look away.
A little sag is normal, especially if you've used your breast for breastfeeding. But if it's that kind of like, you know, I always say like my grandmother's arm is like, it's nice and fatty. You put your head on it, it's so soft and pillowy. That's a less dense breast.
Got it. Okay, it's soft and squishy and nice. Okay, what are the recommendations for screening if you have dense breasts?
So there's no specific recommendations if you have dense breasts. But we do know that, especially if, and I encourage people to go to breast screening centers. So those are often attached to hospitals, like we have one in Scarborough, Women's College has one, because we have dedicated radiologists that read breast mammograms. Oftentimes, if it's quite dense, they will recommend doing an ultrasound, or if there's a suspicion for something, an MRI.
If I demand, I want a mammogram before 50, is there a way I can get one? I've had one already because there was something, so they had to check it out. But what if you're not in that situation?
I would say that, it's part of its advocacy for yourself. You simply can say, you know what? These are the reasons why I think I'm at risk for breast cancer. This is what I'm nervous for. I would like a mammogram. They will not turn you. You can't self-refer in Ontario, but you can ask your practitioner, your primary practitioner, that I'm concerned. I want a mammogram. So 100%.
Very good, doctor. Thank you for that, Dr. Omole. We're headed to break. We've got more Cityline coming up. You're awesome. Thank you. Be right back. That was great. Coming up, Dr. Tony on menopausal hormone therapy and a surprising benefit.
Other benefits include things like the skin texture improving with use of menopausal hormonal therapy.
That's nice.
I know, right? And reduction in the appearance of wrinkles and fine lines. So
really? Welcome back. Many women going through menopause, no symptoms, can significantly impact their lives, which is why treatment options need to be more openly discussed, and that's what we're doing today. Family physician Dr. Tony Sappong is here to break down what you should know about menopausal hormone therapy. Give it up for Dr. Tony. Thanks for joining us.
thank you.
First things first, what I just called it was not hormone replacement therapy. I called it menopausal hormone therapy, and that's because it's undergone a bit of a rebrand, right?
Yeah, exactly. Hormone replacement therapy implies that we need to replace something, that there's a defective state that exists if our estrogen and progesterone declines after menopause.
Yeah.
This is in fact a normal and expected course for all women. So it's undergone a rebrand just to really reflect reality.
What is it, and why in the past has it been so controversial?
Yeah, so menopausal hormonal therapy is the use of hormones to treat symptoms of the menopausal transition or, menopause itself. In terms of why it's controversial, that largely came out of a study called the Women's Health Initiative. This was the first major study, randomized control trial that we did that looked at the health benefits and risks of menopausal hormonal therapy. The initial results were quite startling. They found that there was an increased risk of breast cancer, heart attacks, strokes, and blood clots. And so the study was actually terminated early, and it led to like a plummet in how many women were actually being prescribed menopausal hormonal therapy. What we now know, so we've gone back and we've reanalyzed the data, and a couple of things have really stood out. One of which is the fact that the average age of women in that study was 63. And if you think about the fact that the average age of menopause is somewhere between 50 to 52, this means that the majority, or at least over half of the women who were in this study, were being given hormones after their bodies had not really had any normal levels of estrogen and progesterone for over a decade. And as it turns out, that's really important. What we now know is that for women who are under the age of 60 or who are within the 10 years from their last menstrual period, the benefits of menopausal hormonal therapy actually outweigh the risks.
So the age group of the folks that they were studying and the fact that they had not been on estrogen or had not had any estrogen for many years
stopped making it,
made it a difference and made them more susceptible to these blood clots and heart issues and cancer and interesting. That was a big one because I remember growing up with an aunt and she said, you know what, I don't care what they're saying, I'm going on HRT. She's like, I'm not living my life like this, and she did it. And she's had no complications. She had no complications since. So, and I remember thinking, ooh, what a risky thing to do. Meanwhile, we find out that the study is faulty.
Yeah, it's just we now know more.
We know more.
We know more now.
Any other myths you'd like to bust when it comes to menopause? Because I feel like there might be a few.
Yeah, for sure. I find it helpful to talk about the breast cancer risk because that's often one that women are really worried about.
Yeah.
The Women's Health Initiative found that there was a 26% increased risk of breast cancer. What this actually translates to in real numbers does not mean 26% of women are going to get breast cancer. If 10,000 women are on menopausal hormonal therapy, we see an additional 6 to 7 cases of breast cancer per year.
Okay.
Meaning that if you put that in a percentage, 99.94% of women on menopausal hormonal therapy are not going to have any problems with breast cancer. So it's a very small risk. We also know that that risk really only applies once you've been on menopausal hormonal therapy for 5 years or more. So less than that time frame, the risk is even less. So that's important to understand. And so I think it's just really important that we have these conversations with women so that they can assess the risk for themselves, right? Because, I'm not in the menopausal woman's body. I don't know how severe their symptoms are. And, it might be worth it for them to be able to treat some of their symptoms while still accepting this risk of breast cancer.
Right. And you said something important. We could assess that ourselves.
I really believe that with the information, women can make their own decisions for themselves.
Right. Instead of struggling through maybe symptoms that can be completely helped with little risk. So who would you say should be thinking about menopausal hormone therapy? Is that it?
It's a mouthful, yes.
Who should be thinking about it and who should just say forget it?
Yeah, so basically, if you are within 10 years of your final menstrual period, you're less than age 60, and you have symptoms like vasomotor symptoms. So these are hot flashes or night sweats. Can be helpful to treat that. If you'd like to prevent or reduce bone loss, so osteoporosis, menopausal hormonal therapy is known to help with that. And the last sort of indication is to treat the genitourinary symptoms of menopause. So this is vaginal dryness, irritation, sometimes urinary tract infections. So certainly, if you have any of those symptoms and you'd like to consider MHT, you would be considered a candidate. People who would not be considered candidates are women who have had a personal history of breast cancer, heart attacks or strokes, because they would be at higher risk. And then also women, if they have high blood pressure or abnormal vaginal bleeding, those might have to be investigated and treated before starting menopausal hormonal therapy.
Should you even think about starting hormone therapy if your symptoms are manageable? Do you have to wait until symptoms are unmanageable and you just kind of have a crappy quality of life before you think about it?
No. There is no magical age or threshold where we say, now you can have menopausal hormonal therapy. I find a lot of women, they don't talk about menopause even amongst themselves, and so they're often struggling alone, and that's really hard. In silence. That's not great. So I would say, like, if you're at all considering it, if you're having symptoms, talk with your family doctor because you can better decide whether or not it's appropriate for you.
I want to talk actually about some benefits and side effects. Are there benefits and side effects of doing hormone therapy?
Yeah, totally. Apart from like the benefits for hot flashes and night sweats and those sorts of things, we know there's other benefits that are less well known. So, for instance, it can really help with sleep. And this is often because night sweats and hot flashes.
They feel like night flashes.
Right? They might be night flashes.
Yeah.
Often disrupt sleep. Menopausal hormonal therapy is also really helpful for treating the mild and moderate symptoms of depression, which we find are very common during the menopausal transition. It actually reduces women's risk of things like colon cancer and diabetes, which, again, super important to know. And then a lot of other benefits include things like the skin texture improving with use of menopausal hormonal therapy.
That's nice.
I know, right? And reduction in the appearance of wrinkles and fine lines. So
really?
And that's just a small centering. So,
and I mean, it depends on who you are.
Absolutely.
We haven't talked about weight. I mean, asking for a friend about visceral belly fat. We know that this happens with a lack of estrogen, right?
Yes.
So, can the hormone therapy help this situation?
So what we know about menopausal hormonal therapy is that it does not cause additional weight gain.
Okay.
Unfortunately, going through menopause and getting older just means that naturally our muscle mass decreases and our fat unfortunately increases with time.
Yeah.
And so we often put on weight during the menopausal transition. It is not well known whether the menopausal hormonal therapy reduces that. Most likely, unfortunately not. The doses are actually quite low.
Come on,
so
doc.
it's unlikely to
do
be able
some
to
research for me and come up with another answer.
I'll get right on that.
It's good to know. Listen, there are tons of benefits, and if it's making you feel like you're living life more to your fullest with a low-ish risk.
That's it.
You know, why not? Okay, such important information. Thank you, Dr. Tony. After the break, we have a familiar face joining the conversation to talk about how menopausal hormone therapy has changed her life. Stay with us. Good info. Coming up, a first-hand account of the effects of hormone therapy.
You know what? Within about 3 weeks of starting, I started to feel like myself.
Welcome back. We are busting myths about menopausal hormone therapy with family physician Dr. Tony. And joining the conversation is Cityline model Lori Donnellan. So we usually see her on Fridays. I love that you're here with us today because we want to talk about your own journey with hormone therapy. Why did you decide to explore this option, Lori?
Well, you know, I'm lucky to have a few friends that are a few years older than me, and they were trailblazers. Some had great response to HRT. One ended up with blood clots and had to come off it. So when I was approaching my 50th birthday, I started to feel the symptoms coming on, and the night sweats and the hot flashes. Oh my gosh, they were insane. Every 15, 20 minutes all evening. It was
constantly,
constantly. Yeah. So I approached my doctor and I said, you know, I feel like I'm just not myself. I felt a little lackluster. My skin felt dry. My hair felt like it was thinning, and those hot flashes were killing me. So we talked, and the best option for me was to go on an oral HRT.
How long has it been?
It's been exactly a year.
Okay, so what's going on? How you feeling?
You know what? Within about 3 weeks of starting, I started to feel like myself. The hot flashes went away almost immediately. Within 2 to 3 weeks, I was already starting to see it. I started to sleep better, and I think that was starting to just make me feel better in general, right? When you get a good solid 8 hours. My skin felt lighter and brighter and clearer, and I went to a hair appointment about 6 months in, and my hairdresser said, "Oh, you've got all these little baby hairs. What are they from?" And I thought, oh, that's estrogen coming back.
So new hair growth, the whole nine.
Yeah.
Okay, so the one thing that was sort of holding you back a bit was your friend that had blood clots.
Right.
She had experienced that. Dr. Tony, can you talk to us a little bit about just this relationship with being on hormone therapy and blood clots?
We actually have some newer formulations of estrogen now. So there's transdermal applications. So these are patches, creams, gels, or a vaginal ring that you can use. And because they bypass the normal processing that happens if you ingest it orally, it actually doesn't have any of the increased risk of blood clots. So it's really important to recognize that if that's a concern for you, if you've had previous blood clots, you could still be a candidate. You would just need to use a transdermal.
Yeah.
Oral menopause hormonal therapy does have a slightly increased risk of blood clots. That risk increases with age. In terms of actual numbers, again, if there's 10,000 women on menopausal hormonal therapy, there's about 8 to 9 on average new blood clots in a year's time.
Okay.
Lower if you're closer to 50, higher if you're closer to 60.
Okay, good to know. I started HRT, but what are we calling it now? Help me out.
MHT, menopausal hormonal therapy. I know, it doesn't roll off
Okay,
the tongue.
now MHT. I started MHT a couple of weeks ago. I've got my 13-year-old. Every time I start getting irritable, she's like, is the estrogen working yet? Like, when does it work? When does it click in? I'm like, honey, give me a few weeks before I start to feel the difference. But it was really good, number one, having a woman doctor who immediately was like, oh, I've got some things for you. Let's consider these things if you're having hot flashes and feeling irritable and all those things. So I will report back. I will let you know how I'm feeling, but I'm happy to be on the road to Lori. I want to go where you go, Lori, because that's what I'm looking for. Advice to women who are interested in menopausal hormone therapy but still on the fence about it.
Yeah.
I'm going to get you to answer that while I go out to the audience.
Definitely.
What would you say to them?
I'd say definitely chat with your family doctor. They have a lot of information. Also, things to keep in mind, helpful to educate yourself. There's a really wonderful book called The Menopause Manifesto, which is written by Dr. Jen Gunter, who's a wonderful obstetrician gynecologist. It has all the information that you need. The North American Menopause Society also has some really fantastic resources for people, both doctors and patients, on what to do about menopause and how to approach it.
Great. Dr. Gunter has been on the show. We are a fan. She's fantastic. This is Elizabeth. You had a question for Dr. Tony.
Yeah, doctor, do you know why MHT works for some women and not for others?
Look at her picking up the new name quicker than I did.
Well done, well done. Very impressed.
Yeah.
Yeah, like all of our medications, unfortunately, there are some people who respond to them and others who don't. There are some newer formulations, like I was talking about with Tracy. So some of the newer products are sort of closer to our physiologic hormones. So it might be worth a try if it's not working for you to talk with your physician about changing the dose, changing the medication, and considering other options, because there are other options. It's not a one-size-fits-all, unfortunately.
And once again, I guess if you're with a physician that is not sort of listening, ask for those other options, right?
How long does it take to kick in, usually?
Yeah, so typically we say about 6 to 8 weeks. I feel like Lori got the benefits quite quickly, which is fantastic, and I wish that happened for everyone, but sometimes it can take a bit longer before we start to really know.
Good stuff. Thank you for your question, too. That was great. We're going to go to break. We got more coming up. Stay with us. Good questions. Have you tried it? Coming up, it's the biggest killer of women in Canada.
Underaware, underdiagnosed, under-treated, under-researched and under-supported.
Cityline's Wellness Wednesdays is brought to you in partnership with Jameson Vitamins. For everyday immune support, Jameson is here for your health.
Welcome back, everyone. They are a silent killer that can strike any woman at any time. Heart attacks, strokes, blood clots. Heart disease is the #1 killer of women in Canada. I'll say it again. Heart disease is the #1 killer of women in Canada. Here to help us understand the reality behind the statistic is cardiologist Dr. Paula Harvey. Please welcome her. Thank you for joining us, Dr. Harvey. So your work at Women's College Hospital is specifically focused on women's cardiovascular health. Why should women be more concerned?
Well, as you alluded to in the introduction, heart disease, cardiovascular disease is the #1 killer of women in Canada. And if we were actually to ask women what they think is their major health risk, as we did in 2017 when 2,000 women were asked this question, the majority actually said breast cancer. And yet cardiovascular disease is going to kill 5 times as many women as breast cancer. So we have a real issue with awareness of cardiovascular disease, and that's one of what we refer to as the 5 unders. So underaware, underdiagnosed, under-treated, under-researched and under-supported. So the under-research is really an important part of this as well, where we need to increase awareness, increase research, so we can actually improve those statistics. It's very important.
Very important. So break it down for us. How does heart disease cause heart attacks? And then let's talk about strokes.
So the heart attack and stroke come under the umbrella of cardiovascular disease.
Yeah.
And the most common cause of heart attack and stroke is what we call atherosclerosis, which is basically due to inflammation of our arteries, which leads to build-up of what people would refer to as cholesterol deposits. So we call them plaque. So you get plaque in the arteries to the heart and to the brain. That plaque, when it continues to be inflamed, can become complicated, and it can rupture or become ulcerated. And where you have that complication, a clot can form. If you form a clot there, then you block off all the blood supply to that part of the heart or that part of the brain. You no longer get oxygen or nutrients. And if you don't get rid of that clot, either by clearing it or dissolving it, you end up with either a heart attack, which is where you have damage to the heart muscle, or if we're talking about a stroke, it's damage to the brain. So they're both part of cardiovascular disease.
Okay, and that's the difference between the two. So the major symptoms women should be looking for, what are they for heart attack?
So for a heart attack, women can present like men do with what we refer to as the Hollywood heart attack, clutching the chest and sweating like we see in the movies.
Yeah.
But women can also present with different symptoms and often articulate their symptoms differently to men. So women may talk about a pressure or a squeezing in the chest that may go up into the neck. They may have palpitations, they may have profound fatigue, cold sweat, even stomach pain or pain into the back. So
like nausea is ever?
Nausea, yep. So it can be any one or combination of those symptoms could mean you're having a heart attack.
What about stroke symptoms?
With a stroke, this is when you're having damage to the brain. And we do use an acronym to help people understand what sort of symptoms they might have. And this is it's B FAST, and it refers to B is for becoming unstable, wobbly on your feet. E is for change in vision, so you may have a change, you may see double vision or lose your vision. Then F is for face, you may have problems with drooping of the face, even drooling from the mouth.
Yeah.
A is what you may have weakness in your arms or legs, so if you hold out your arms, one of your arms may droop. S is for speech, either difficulty with speech yourself or understanding people's speech. Any of those symptoms may suggest you're having a stroke, and the T at the end is time to call 911. And so for both of those conditions, you need to be calling 911 so that you can stop the heart attack or stroke.
And there is a good chance that the faster you get help, the less damage it's going to do. Is that correct?
Oh, absolutely. These are emergencies. So if in doubt, act. That's the important thing, because if we can get rid of that clot, then we prevent the damage, prevent you having a completed heart attack, prevent a stroke. It's critical.
So how do we reduce our chances, our risk of cardiovascular disease just in general? What should we be doing?
So it's really important for women to understand they can make a big difference to their heart and brain health, and that at least 80% of your risk can be reduced or wiped out by addressing risk factors. So for women, that means traditional risk factors. So making sure that you're not sedentary. Unfortunately, a lot of women are sedentary, overweight, not smoking, addressing if you've got diabetes, high blood pressure and high cholesterol. And then there's other risk factors that are very specific to women that also need to be addressed and that women need to be aware of. So healthy lifestyle, knowing what your risk factors are and knowing how to treat those risk factors and how to implement lifestyle, and if necessary, working with your clinician medications to reduce cardiovascular risk is really important.
So how many of you in the audience, just by a show of hands, how many of you thought breast cancer was the #1 killer of women in Canada? Quite a few hands there. Why is it that we thought, I thought anyways, that it was men that were having the heart attacks, and it's because they were traditionally the breadwinners and they're traditionally the ones that are stressed out, and then women were catching up because now we're also breadwinners and we're also in the workforce. Is all of that a myth? Like, was any of that true?
It's, part of this comes down to the unders that I mentioned, and particularly the under-aware and the under-researched.
Yeah.
All the research was being done on men. And that's whether you're talking about in the lab or clinical trials. Everything to do with heart disease was all focused on men. Our treatment was focused on men. And part of that problem was that all the cardiologists were men. All the researchers were men.
Yeah.
We are seeing a change now. I'm not the only woman working in cardiology these days.
Thank goodness.
Having that, that input and that voice and starting to recruit women into clinical trials, making sure actually it's made mandatory now to make sure that you're recruiting women into trials so that we are aware of what is going on, that we are testing treatments, we're testing diagnostic tools, and that we're supporting women. So it's not a myth. We were thinking it was all men.
Right.
And the women were looking after the men.
Right, but we were having heart attacks at the same time.
We were having heart attacks at the same time.
No one was just looking at us.
Exactly.
Okay, you say hormones and age play a big role in our risk for blood clots, our risk for heart attacks, our risk for strokes. Why is that?
So hormones are really important to women. We know that premenopausal women are generally protected against cardiovascular diseases, and that's at least in part due to the estrogen that we produce from our ovaries, that is protective, protects against high blood pressure and high cholesterol and things. When we go through menopause, that changes. So the hormones are really important. You need to, especially as you're moving through menopause, know that you're going to be at increased cardiovascular risk. But we also have other risks related to our hormones over our lifespan. So pregnancy is really important. It's a woman's first stress test. And there are complications of pregnancy like diabetes and high blood pressure in pregnancy that put a woman at higher risk of both those risk factors and heart disease at a later age. The contraceptive pill increases risk of stroke, particularly in women who smoke. So we really need to think about our hormones and what's happening with our hormones over our lifespan combined with age, because that really impacts our cardiovascular risk. And we're starting to learn about that. But many clinicians still don't pay attention to it. They don't ask about it. And women themselves need to have this knowledge so that they can say, hey, I had gestational diabetes. That puts me at risk 7 times the risk of diabetes in older life and double the risk of cardiovascular disease, just as an example.
I did not know that. I remember being tested for gestational diabetes and actually liking the orange juice they gave me. I was like, oh, that's delicious. Maybe it's because I ate everything when I was pregnant. But I wasn't diabetic, but I did not know if I was, my chances of having diabetes later were increased. I didn't know. This is information that isn't passed on to us. So thank you for the work you do and for all the info you gave us on the show today. Thank you so much.
My pleasure.
Dr. Paula Harvey, everyone. For more information on women's health, heart health, visit our website, cityline.tv. We're going to go to break. We'll be right back. Thank you.
Now you can have Cityline's experts at your fingertips.
So spill the tea. What's the secret?
Upload your video questions to submissions at cityline.tv. Escape with Cityline.
It's time to join the party. We want to shower you with fun, prizes, and unbelievable surprises. Are you ready for this? Head to cityline.tv/tickets and see the show you love come to life. Well, we have come to the end of an incredibly important show highlighting what women need to know about their health right now. Did you enjoy the show? It was a lot of info, huh? A lot of info. I was saying to Tony and Lori, I mean, me hosting this show, the major perks of hosting this show is that I get access to all of this information all the time. The best experts in Canada coming on here and informing us. And I love that we can share that with all of you because this is crucial information that we need to know. We need to know how to advocate for ourselves. If you go in and your physician is just like, don't worry about it, you're fine. You have to find the courage to say, I'm not okay. I'm not feeling okay. I want a second opinion. And then you've got to go and you've got to find that second opinion. So thank you so much to the amazing experts for joining the conversation, for Grace and Lori for talking about your experiences. If there's a topic that you want to see on the show the next time, share it with us across our Cityline social media channels. Thank you all for tuning in. We'll see you the same time, the same place tomorrow. Take care of yourselves, everyone. See you then. Mwah.